save our time, we'll go straight to the next lecture on heart failure. This lecture will be delivered by the Group Managing Director of the Limi Hospital, Dr. Iseko Iseko, a cardiologist par excellence, passionate physician, and passionate about putting Nigeria on the map and reducing medical tourism. He's witty, teaches effortlessly, and I'm sure would benefit a lot. Please put your hands together for him.
Thank you. I hope I can live up to all those hype. All right, good morning, everyone. Everybody looking cold. Can we stand up 1 second so that we don't have a cardiovascular risk of sitting down? Stand up just 1 second. Stand on your toes, up on your toes, come down, on your toes again, up, come down, on your toes again, up, come down. Now take a deep breath in. At least we don't have NYK4, Abby. Again, in, hold it. Now breathe out all your problems. Now let's have our seats. Let's clap for ourselves. Great. We know that sitting is the new smoking. It's one of the important cardiovascular risks. So let us not also fall foul of what we are teaching. Thank you, Novartis, Dr. Oyinka, for that fantastic presentation. Thank you, Dr. Olalekon, also for hypertension presentation. All the slides will be sent to the emails you put there. So we'll send you the slides for all the lectures at the end of the meeting. Please make sure that your email was written legibly so that you can get the slides, and then you can share the slides widely. Share it in all the WhatsApp group. When people are posting rubbish, post your own too. Let's share it widely. We want Nigeria to be better, truly. So I'm talking about heart failure. All right, my name is Iseko. I work with Cardio Care Hospital. I also work with the Limi Hospital Group in different capacities. So with Cardio Care, I work as in cardiology and interventional cardiology. And in Limi Hospital, I work as the Group Medical Director. So, but today we're talking about heart failure. I will try and focus it on standards and protocols. So it will be as simple as possible. All those big stuff that they used to move, we may not move it as much. But trust me, I still know it. And if I don't know it, Professor Dambaji is around, Dr. Reko is around, Dr. Inuwa is around, different people are around, and Dr. Edafe is around. Welcome, Dr. Edafe, our lead interventional cardiologist. Thank you very much for coming all the way from Port Harcourt. Okay, so this is a simple pretest. Can we look at all of this? We want both nurses, doctors. I pray next year I want to subdivide this conference a bit. I'm thinking about it. We have a 52-year-old newly appointed minister. Our first case. Listen very well. Newly appointed minister. He noticed palpitations at rest. His heart was doing getting. And he was unable to complete his usual golf game. So when he walks, you know how you play golf? You do 17 holes or how many 8 holes you walk. He found out that I can't continue. I can't complete game with others. I have to stop. I will tell them to go ahead. Initially, he thought it was because of stress and that the new office was attributing a lot of stress to him. Last week, however, his brother died in his sleep. So because of that, he rang up the hospital. I beg, I don't want to die. He has never been told to have hypertension or diabetes. 8 months ago, he had a checkup in abroad. How many people have seen those patients? They had a checkup in abroad. I'm using my words specifically. Don't see I'm swelling English. And nothing was found. On examination, he looks well. He's not breathless. His legs do not look swollen. And there's not even really a mild, there's a mild dimple. When you press for 5 to 10 seconds before you now see a mild dimple. The pulse was 102 per minute. The blood pressure was 132/98. Heart sounds were not checked. KVP was not checked. I mean, this is a minister. His orderly is outside. Military men are around him. So, go fine. It's okay, he's sitting down. He's wearing Babariga. So, question number 1. What do you think? What should we do for him? What should we do for him? What should we do for him? Can we have a mic? One of the ushers, please take one of the microphones. What should we do for this man? He's in your clinic and this is what you found. Yes, somebody bold. Anybody? Anybody? Raise up your hand now. Thank you. Thank you very much. Give her. Yes. I did raise up your hand. Yes, good. Fine. Go ahead.
Good morning, everyone. I think you should forget about the fact that he's a minister and
Forget that he's a minister.
do a comprehensive physical examination.
Okay, so he should move that Baba Riga.
What? Yes.
Thank you very much. Okay, now he has moved your Baba Riga. You have examined him. Heart sound like S1, S2. You are not particularly sure whether there was S3. Because when Professor Tambaki was teaching it, you were saying yes, sir, Ali and the angel. He said, did you hear? You said yes, I heard. How many of you heard when you did not hear when you're in medical school? Prof, we are all confessing. We did not hear. All right. So now you are a minister. Everybody is looking down at you. In fact, you may be in the newspaper tomorrow. So you are not sure about that S1, S2. Okay, so what will you do? That's his blood pressure. Yes. Somebody with. So what will you do? Blood pressure is 138/98.
You do an ECG based on the palpitation that he complained.
You do an ECG based on palpitations. Okay. As a nurse, very correct. Yes, what else? What else do we do? I'm just giving them time. Mr. Nokela, please let me know when I'm ready to go ahead. Or start projecting my slides. Let me continue. Okay, so this is the minister. Blood pressure 138/98. JVP and heart sounds not checked. But somebody said we should check. Now we finally checked and we are not sure. We heard something. Okay. Now the next thing. What do you think we should do? Can we go on the polls? cardiocare.ng/polls. This one, you're anonymous. Nobody will know what you wrote. So don't worry, we can't laugh. Go ahead, cardiocare.ng/polls. What will you do? Let him do some lifestyle modifications. He should rest. It's stress. You know, to be a minister now is not funny. He has hypertension. He needs hypertensives. He has anxiety from his new post and his brother's demise. Give something to calm him down and then review again after the burial. Then, why all of the above go above? All of the above. And then E is there. I'm not seeing the E. I don't know, Jare. I need to evaluate further. How many people have seen? I don't know. It's not showing very well on the screen, but let's continue. Lifestyle modifications, okay. Review again in 2 weeks. I don't know. I like when people say I don't know. He has hypertension. He needs antihypertensives. So by Dr. Olalekan's definition, he said if you have sustained 140/90, doesn't he have hypertension? 138/98. All right, beautiful. Beautiful. So when you see a split like this, there is like Nigeria election. We need to go to the courts to find out what is the correct answer. So let's go next. So what is heart failure? What is heart failure? Heart failure, putting together, there are several definitions from different societies. ESC, Heart Failure Society of North America, American College of Cardiology. So let's put everything together and try and have a simplified definition for everybody in this audience for ACS 2023. A chronic is progressive. It is a neurohumoral syndrome, meaning it's endocrinologist management, neurologist management, perpetuating cardiac dysfunction characterized during stress and or at rest by difficulty in breathing, pulmonary and or systemic venous congestion, and or inadequate peripheral oxygen delivery, and finally shortened life expectancy. Prof, I hope I was able to combine everybody's own together completely. We hope nothing is missing. I try to put all the keywords from all the different societies to form one that we can easily follow. So see the keywords. Number one is chronic. You have to say something, sir.
Well, heart failure is a clinical syndrome.
Clinical. Okay, clinical is missing.
Yes, it's a clinical syndrome. You don't make the diagnosis from the lab or from X-ray or from cardiac catheterization.
Exactly.
Or from echocardiography. It is a clinical syndrome and must be defined as clinical syndrome. Thank you very much.
Thank you very much, Prof. So that's why we have the Prof in the house. So remember that it's clinical. Remember that it's clinical. And so those, go back to my slides, please. And so those things you are looking at there, these things you can see most of them clinically, or you can take the history. You can see signs of pulmonary or systemic congestion. You can take the history of difficulty in breathing, which is typically progressive. Typically progressive, starting on moderate exertion and slowly progressing to difficulty in breathing at rest. Typically, it is not sudden, typically progressive. Then you have pulmonary signs. You can pick all of these finds. But once you have picked these clinical findings, you must remember that there's a life expectancy problem and it is chronic, number one. It is progressive, number two. And it is a neurohumoral syndrome, number three. That should give you a direction to how you are going to treat. You must remember this. Don't forget, remember this. Why must you remember this? So that you don't end up into the trap of furosemide and digoxin and sloke. So that you don't end up into that trap. You have leg swelling, take furosemide. The patient comes back, God doctor, everything don't dry, and you are fine. No, you must remember that these things are outward appearances of something that is happening, that is chronic. It is relentless. It is progressing, whether you can see it or not. Okay? So those are the things you must put together in understanding what heart failure. If you understand this one, in fact, my job is done. One of the reasons why we put together ACS was this. When you see somebody that has been managed, quote and unquote, for heart failure for 2 years on furosemide, digoxin, and aldomate or amlodipine, because somebody did not take cognizance that this is chronic, this is progressive, this is a neurohumoral syndrome, and this is what you must remember when you are managing. So how does it happen? There is some kind of cardiac muscle injury that happens. This is work published in 2010 in New England Journal of Medicine. There is some cardiac muscle injury from hypertension, which is still the most common cause in Nigeria. And even among the patients we have taken to the cath lab, Dr. Jaffe was here, we do not see as many patients with ischemic heart disease still now in the cath lab. So hypertension is still number one. And other causes. That leads to a ventricular remodeling. The heart has to adjust to compensate for this, new injury or new dysfunction. This now leads to electrical instability and cardiac dysfunction. That is the heart is not working well. Now that cardiac dysfunction can be either systolic, diastolic, or both. Now I've seen a lot of people that just open the echo results, go straight to ejection fraction. Ejection fraction is 57%, 60% cannot be heart failure. Fear out of the window. This is why you must understand this. Once you understand this, every other thing I will say now will not make sense. It could be either systolic, diastolic, or it could be both. In fact, in most studies, almost 50% of patients have normal ejection fraction. So, like Prof said, it is a clinical diagnosis, okay, including some studies from Nigeria. Now, all of this, including ventricular remodeling, lead to something gets activated. The nervous system gets activated, and the hormonal system gets activated. And that now perpetuates the cardiac muscle injury. This thing was supposed to be a good thing, just like removal of fuel subsidy. It was supposed to be a good thing. But then it came back and caused more damage. And that damage caused more damage. And yesterday I passed by first, and the fuel was 650 naira, and everybody was quiet. I said, 650 now. I can't believe it. And it comes back and it causes more things, and it causes more instability, and it causes more dysfunction. Prof, I hope I'm defining heart failure well. And that comes back to worsen the fuel price again, which was supposed to be liberated or something, I've forgotten, deregulated. Then it comes back. This is how it keeps on happening. Vicious cycle. The more it happens, the more other things happen. The more it happens, the more other things happen. This is a critical part of heart failure. And once you understand that. So, 3 critical systems. These systems are the 3 systems we target when we are treating heart failure. Once you understand it, when somebody is prescribing, you say, sir, what about this? And I always love it when my nurses say, sir, this heart failure treatment, on the treatment sheet, I cannot see spironolactone. Something is missing here. Sir, I cannot see empagliflozin or something. Something is missing here. Sir, what of sacubitril valsartan? I can't see it here because they can see that this is what we are treating. We are not just treating leg swelling, which is important, but we are not treating that. So there are three key things: the RAA system, renin, angiotensin, and aldosterone system. Number two, the sympathetic nervous system, and number three, the natriuretic peptide system. These three systems are an integral part, and they were started to solve the problem. So for a large time, patients start feeling better when the heart failure syndrome. So before they come down, really, these systems have now become detrimental in their effects. Okay, so what causes heart failure? So what causes heart failure? So most of our clinical practice tell us that heart failure is typically caused in this: hypertension, cardiomyopathy, coronary artery disease, and valvular disease. In our clinical practice, this is what we see in cardio care hospital amongst the 4 or 5 cardiologists that work there. This is our typical findings. I think it's the same in most centers around the country. In the sub-Saharan African survey of heart failure, hypertension was 43.9, DCM was 19.5, rheumatic heart disease was 15%, ischemic heart disease still somewhere in between. Okay, so these are all the different etiologies that also come in. But remember that these 4 are typically the ones we see in most of our Nigerian patients. And most of our Nigerian patients, hypertension number 1. And even if hypertension is not the primary cause, it may be the perpetuator. It may be something that makes sure the patient does not get well. So that blood pressure must really be well controlled. In heart failure, you cannot accept 95. You cannot accept 92. That is how serious sometimes it can be. Okay, so how do we classify heart failure? How do we classify heart failure? We have 3 ways to classify heart failure. 3. The first is based on echo ejection fraction. That's a very simple way. The second is based on dyspnea severity. How much is the difficulty in breathing? And the third is based on cardiac dysfunction cause. Now, there are so many other things, but this is what I want you to just keep in mind. Because ACS is about getting getting the big knowledge into our clinic rooms. That is if there's a tagline for ACS, is getting the big knowledge into our clinic practices. So keep these 3 things. We will not go too technical. Number 1, we define either there is reduced ejection fraction or the ejection fraction is normal. I know there are other things in between. But for this meeting, these 2. Number 2, we define the NYHA class, the New York Heart Association. How breathless is this person at rest or activity? If they are breathless at rest, we say they are class 4. And if they're like you and I, almost no breathlessness, we say they are class 1. And 2 and 3 somewhere in between. Quite simple. Then we now come to the cardiac dysfunction course, which is American College of Cardiology and AHA, American Heart Association, which is A to T. So this is what it looks like. In this cardiac dysfunction course, we define heart failure into 3. The first is anybody with a high risk of heart failure, but they don't have symptoms and they do not have structural heart disease. So in this regard, most patients with hypertension, with dyslipidemia, are already class A. The reason for this classification is so that we don't think that anybody with hypertension is docile, that is just 140/90, just 140/100, don't worry, 150/100. In our mind, we should begin to think that this patient is already class A heart failure. We should have that in our mind, so that when we are treating them, we do better. Next, we say, okay, they now have left ventricular hypertrophy. They have some dysfunction happening. They have diastolic dysfunction, but they don't have signs. We want to still classify them as if they have heart failure because their heart has started making changes. Then we now come to C and D. In C, we have symptoms of heart failure, either before now or currently. And in D, they are advanced. Typically, those are on admission. And all the patients in the NYHA class are typically from C. And D are typically the ones in class 4. Okay? Ordinary activity does not cause any symptoms. They don't get breathless ordinary activity. It's class 1. 2, ordinary physical activity results in some symptoms. 3, less than ordinary activity. So what do we say is less than ordinary? What do we say is ordinary activity? We say that, for example, walking from here out there to the gate, maybe up a flight of stairs. That is maybe 1 flight of stairs, relatively ordinary activity. Okay? And then 4, they have symptoms at rest. In 3, they can hardly even just wear their clothes. They are fine at rest. Once they wear their clothes, they are still somehow fine. Once they will stand up to go to the toilet, there's some breathlessness. After the toilet, they have to sit down in the toilet. There's some breathlessness. But at rest, they're relatively fine. So they are already getting there. While 2, a flight of stairs, flight or 2, will now see them in that regard. Okay. How do we recognize and diagnose heart failure? These are the questions on our minds. These are the questions we need to be able to put together. So, there are many signs and symptoms, including patients that are asymptomatic. If they are asymptomatic, remember on the ACC classification, they are still stage B. We have seen a patient that all can remember. The patient came in for a routine checkup, a twin. His brother died of cardiac dysfunction, and then while he was trying to japa, those people, they do clinical exam, I think. They sent him that his X-ray had some cardiomegaly. His ejection fraction was 16, and the guy was perfectly fine. His heart was massive, 20 something, and his twin brother had died of a heart-related condition, and he was fine. Do you understand? So some of them are also asymptomatic. Okay, so you should keep that in mind. Now remember that the dyspnea is typically progressive. It starts some exertion, then after a while they cannot walk to their car, and after a while the driver has to bring the car closer. Do you understand? Slowly. Then they cannot lie down and sleep. Or sometimes the patients will tell you they slept off, they woke up, then they could not breathe. Then they went to the window and opened the window, and voila, their room is too hot. Have you heard that? They say the room is too hot. No, the room is not hot. What they have is what we call paroxysmal nocturnal dyspnea. They have difficulty in breathing at night, which happens intermittently. Once they lie down and sleep, heart is unable to move around because there's not much support. Fluid goes to the lung. Once it fills up, they sit up. That going to the window or opening is red herring. After a while, the movement, the calf muscles, the sitting up allows fluid, and the person can breathe a little better. They go back to sleep and they wake up again. Or some people, they will say it was a bad dream. Okay? So a witch was chasing them in their dream. So they woke up and they were running from the witch. Okay, so you should be very careful about that. Now they have these other symptoms, leg swelling. Now, I must remind us that the standard for checking for pedal edema is not looking. Neither is it pressing once and seeing. The standard in Hutchinson is to press for 10 seconds. That is the standard. Not to just press and say there's no pedal edema. So in that our case, remember I said there was nothing. Unless you press for a while, for 5 to 10 seconds before you see something. That is pedal edema. Typically, you go behind the malleolus. Typically, medial malleolus or the lateral if you want. Go behind there, press there and sustain it for a while. Typically, you will get most of this. That's the standard. You can go to the foot, but those people that are looking normal, please take some time. It's 5 or 10 seconds. The person has tried. They have come to the hospital. They did not go to what they call it. These people carrying things on their head. Okay, so we need to pick that up. All right. There are other history that you should look out for. Besides the history of the disease, you should look out for history that suggests the cause. History that suggests the cause. History of hypertension, of diabetes, of serious alcohol use. This should be there. Histories of structural heart disease. When I was a child, they said there was something wrong with my heart. History of chest pain and all of that. You should look out for that. You should also look out for history of anything that is making the heart failure come out. So if you have anything, you may even divide your history into 3. And say this is the history of the symptoms. This is the history of the causes. This is the history of precipitants. MI, myocardial infarction. Dr. Babs, welcome. The fluid overload, arrhythmias, dietary indiscretion, medications. All of these, including NSAIDs, ibuprofen, Feldin. All of those could be things that the patient could have taken in large quantities that could precipitate heart failure. You must look for it. Because sometimes patients are on our bed for heart failure and they are still popping 3, 4, 5, 6 tablets of this, and you are wondering why they are not getting better. Okay? So you have to look for these things and what to do. So how do we investigate? Remember, we have said it's a clinical diagnosis. You have a patient with progressive onset difficulty in breathing. You have a patient with some signs of congestion, fluid here, fluid in the lungs, some JVP is raised. You have a patient with one or more risk factors, heart failure, hypertension. You have seen all of that. Now you are thinking, what can I do to investigate this heart failure and do it properly? An echo is invaluable and mandatory. Sir, we don't have echo in our center. Please get someone that has an echo. Remember that we say it's a chronic disease and that it leads to death in over close to 50% of patients. So these are not the people you want to economize with. Now, if they absolutely don't have anything, maybe you can find a way. Okay? But absolutely, you should make sure that you are looking at the ejection fraction. You should look at this, at least if there's nothing more. These things should be in that echo result. So we see all kinds of echo results in our practice, all kinds. But these things should be there. Number one, ejection fraction. And you're looking for, is the ejection fraction above 55 or below 55? For our level, that is what we're looking for. Is it above 55? Now, if the ejection fraction is normal, above 55, then we'll say that the ejection fraction is preserved. Oh, I put the P and the R in the wrong place. We say the ejection fraction is preserved. Okay? Heart failure with preserved ejection fraction if it's above 55. Sorry, that's a typo. And then if it's less than 55, it's reduced. Remember, the heart failure was made clinically, right? This echo is just adding on top. We now come now and we check what is E over E prime. And it correlates well with pulmonary capillary wedge pressure, even in the cath lab. And we look at this. This is missing a lot of echo results. So it's difficult sometimes to be able to marry what the clinical features we are seeing. If this E over E prime is greater than 15, in most cases, then you know that you have a high filling pressure and you know left ventricular endoscopic pressure is high. The patient is typically in acute heart failure. So you see somebody with breathlessness and you are wondering if you do the E over E prime is an echo finding and you see greater than 15 is there. If you do not have E over E prime, send it back. Say, please, I need this something. Okay? Now greater than 12, people that normally compensated on good diuretics and drugs, sometimes it will still be greater than 12. Between 8 to 12 is indeterminate. It could be, it may not be. Less than 8 is typically almost normal in most cases. Okay, so in those cases, if you are absolutely not sure and your clinical history is not good enough, if you can get your E over E prime, your ejection fraction, and your N-terminal pro-BNP, you'll be able to make a way. If you absolutely don't have the clinical skills. But remember, the bedrock of heart failure diagnosis is clinical. Next, we look at the chamber sizes. How big is the heart? And then valve function. We check, are there parts of the wall that are not moving well? And then we do speckle tracking Doppler. Now, speckle tracking Doppler and global longitudinal strain is not available globally in everywhere, but it's available in a number of centers. And it's very, very important, especially in diagnosing some cardiac dysfunction before the ejection fraction starts changing. So you will start seeing a lot of changes here. Even when the ejection fraction is normal, you will see some changes here. It's very, very important. So these are the things that you must be there on the echo. All right, ECG is mandatory. You cannot manage heart failure without ECG. ECG is rarely completely normal, but it can be. Typically, there will be some abnormality there, but it's rarely completely normal and it's mandatory. There are several reasons why it's mandatory. Number one, you can pick some of the things that could have caused the heart failure. Number two, you could pick some of the things that could have precipitated the heart failure. You'll be managing somebody and the patient has an atrial flutter hidden inside the ECG. If you don't find it, you cannot treat that patient properly. All the drugs in the world will not help that patient without treating that. So ECG is mandatory. N-terminal pro-BNP, we do it in most of our patients in cardio care. It's a little bit expensive, but it's a good test. Especially when you are not sure. You are truly in between. Or in those cases we talked about, you are in between, then the echo also did not help you. You fell in this gray area. You do your N-terminal pro-BNP, result comes out in 15 minutes. And it helps. Thyroid function test is recommended in all cases of heart failure, but I know it could affect cost. But in all patients with heart failure, you should do at least a TSH. Very important. It has almost embarrassed me about 7 years ago. I saw a patient, heart failure symptoms, heart failure diagnosis. Every other thing looking fine. Where is this coming from? No hypertension, nothing. Even the chamber sizes were normal. Ejection fraction was normal, but remember we say it's clinical. Until we did the thyroid function. By the time we started treating that, almost all the signs got better. Okay. Kidney function, chest x-ray. In the chest x-ray, there are these 4 things we normally say in medical school, A, B, C, D. Alveolar edema, Kelly's lines, cardiomegaly, upper lobe diversion. But for me, the most important reason for chest x-ray is simply to exclude other things. It doesn't really help in your diagnosis. In fact, I don't always do. So if you don't have chest x-ray, don't waste your energy. Don't waste your energy going to send patient for x-ray. They come back and say the heart is normal. Then you now say what? Or the heart is dilated. Then you say what? Cardiomegaly on the x-ray. Then you say what? You cannot make anything out of that. Okay? So those other ones I say mandatory must be done. So I'll move. And then these other tests are important. D-dimer, glycemic profile, lipids. Just like Dr. Yoinka said, you need to look at the overall cardiovascular risk of that patient. So you need to look at the cholesterol, you need to look at the glycemic profile, you need to look at the Holter ECG in a lot of cases as part of your test. This is standard treatment. Standard treatment. Okay? So, what was the heart failure diagnosis contain? Patient has heart failure is not the beginning or the end of the matter. There are some seats in front. If they are having sitting problems, there are some at least 8 seats or so in front. Ushers. Okay, so what was the heart failure diagnosis contain? It must contain these 5 components. Heart failure on its own is not a diagnosis. Heart failure is a clinical syndrome. When you put this sign plus this sign plus this sign, we say you have heart failure. But that is just a syndrome. It's like saying cough. Cough is not a diagnosis. Right? So now this syndrome of put together symptoms was caused by what? You must have the etiology there. What is the NYHA class of that patient? So when you are sending a referral to a specialist, let the specialist say, wow, this person must have gone to AC. ACS graduates. Yet it have the NYHA class and ACC stage. Then, precipitants. What made this person come to the hospital now? Fluid overload, NSAID use, drug non-compliance, arrhythmia, whatever it is. Then, any other comorbidity. So, for example, heart failure, reduced ejection fraction, secondary hypertensive heart disease, NYHA class 4, ACC stage 3, precipitated by new onset atrial flutter and chest infection with comorbid gouty arthritis. It's like a dissertation, Abi. But this is a complete diagnosis of heart failure. Once you write that one, they should just give you professor. Sir, Abi is okay. All right, great. I hope you're having a good time. If you are not understanding and the thing is getting too tough, just wave to me so that I can slow down a bit. Please, your wave if I'm going too fast so that I can slow down a bit. Good. All right. So, now we're getting to the protocol properly. What do we now say is the case definition of heart failure? Number 1, we have the heart failure syndrome. We have the heart failure syndrome, which is the main thing. Remember, see the other ones are plus or minus, which are that they are extra if you have them. So that case definition of progressive onset dyspnea, of signs of systemic and venous congestion, put them together with appropriate risk factors in the appropriate setting, plus or minus evidence of the laboratory. BMP or N-terminal pro-BMP will be very helpful, especially if you are not sure. And for this audience of which you are not quite sure, your patient is going for surgery, you're not sure, I can see a very powerful plastic surgeon in the audience, that's why I'm saying, this baby, this, that, before you come from Sudan Bauchi. And he says, no. Did you take a proper history? He said, sir, don't worry. I have BMP, sir. At least. Then number 3, you have echo, and you should be looking for these things on the echo. So this is what we put together and say, this should form a case definition for heart failure. Number 1, you have the syndrome. Number 2, you have a positive BMP, plus or minus. Number 3, if you have the possibility, you have the ejection fraction, E over E prime, and other things. So, let's come back to our case again. Newly appointed minister, brother died recently in the sleep. He's never been told to have hypertension or diabetes. Check up in abroad. Sorry, I wrote normal English, but in real thing, in abroad. Was 8 months ago, and nothing was found. I mean, doctor, this was in Germany. Oh, yeah, don't talk to me. I was in Germany. You know Germany. Have you been to Germany before, doctor? I'm sorry, sir. Now here I did. On examination, he looks well. He doesn't look breathless. Legs do not look swollen. I'm sure those of you that have practiced for a while have heard all those kind of stories. In fact, I just left I left the president's office yesterday. What are you telling me? Leg does not look swollen, but there's a mild dimple after pressing for 5 to 10 seconds. But he told that because the shoe is tight, that in fact, this shoe is Louis Vuitton, and sometimes Louis Vuitton shoes can be tight. Okay? Pulse was this, blood pressure of 138/98, normal chest exam. No, we've answered this one. Okay. Paul, is it possible that he has heart failure? Yes, let's go to our polls. cardiocare.ng/polls, I think. cardiocare.ng/polls. cardiocare.ng/polls. If you're online, you can also use what is on the screen. If you're online, you can use what's on the screen. Yes, I don't know. No, yes, no. Don't worry, we'll still go to the Supreme Court. Okay, but this one looks overwhelming. Everybody's saying yes. Prof, what do you what do you think? Let's take our prof's opinion so far.
Well, those who say they don't know, I think they have a reason.
Yes.
Those who say no, I think they have a reason. Because if you say cardiac failure diagnosis is based on major criteria, minor criteria, have you fulfilled it in your
in the history?
in
No.
your history? No. So we're looking for 2 major criteria, or we're looking for 1 plus 2 or more minor criteria. So I'm being technical now. So the person that says yes is probably being taken away by some
Because we're talking about the topic, maybe.
yes. Maybe emotional. Yes, but scientifically or clinically, do we have enough evidence to say this is cardiac failure? I don't think so.
Thank you very much, sir. So, he said, is it possible? Anything is possible. We can fly. Is it possible that this man went to Japan yesterday? It's possible. I'm a politician, Abi. We'll go to the court, sir. All right, great. So we'll discuss the case a bit. So let's go further in discussing the case. Echo showed the ejection fraction of 56%. The left atrium and the left ventricle was dilated. E over E prime was 11. Who remember what the normal E over E prime should be? Okay? N-terminal pro BMP was 800. Normal should be less than 300. Okay? ECG showed relatively fast heart rate and some PVCs. We will learn about PVCs. Don't worry. Hey, when you live here, hey, you tell them to bring it. You ain't go to your hospital, you say, bring it. Don't worry, you will read ECG. TSH was normal. Other tests were normal. Chest X-ray showed some heart enlargement and upper lobe diversion. So now, does the patient have heart failure? I should have added not really. I forgot to add that one. Please answer. As we will not know what you picked, so don't worry. Answer freely. Answer freely. Participate. When you participate, it helps your learning. Our hope is that you live here and this enters your clinical practice. ACS is about taking cardiovascular medicine from the book into the Nigerian hospital consulting room. Okay, so everybody says yes, no. So for a large extent, okay, Daphne, where do you stand? It's a tricky question. The true answer is that it depends. Uh-huh. Whenever you are faced with a tough question, my professor in business school always told me, answer every question with it depends. That way you always look smart and you can enter any direction. So but for argument's sake, we have these features of effort intolerance, which is progressive, which he cannot complete his normal golf game now again. He has some leg swelling, some signs of systemic congestion. His blood pressure is elevated. His heart rate is tachycardic, and the end terminal, and he has a dilated heart. He has signs of cardiac dysfunction, and then the E over E prime is in that gray zone that we are not sure of. So we now did the end terminal pro BNP, and the end terminal pro BNP is significantly positive, and there is no other confounding factor for the end terminal pro BNP to show. So they are false positive, which you should know about, but I will not talk about that now. TSH was normal. We have some signs on the X-ray as well, and so some of these things will now put them together and say, now the question is it more possible or more likely that the patient have heart failure? Sir, please go ahead, sir.
More possible. Or in fact, I'll make a diagnosis of heart failure here. One major criteria: radiological cardiomegaly. Two minors: there is superior edema and there is dyspnea on exertion. So already I'm home and dry. All right, this man has heart failure. It might be that he has a preserved ejection fraction. Thank you very much.
Thank you very much, sir. Let's give a round of applause for Prof. Thank you, sir. This is the first year we are having a keynote speaker, a special lecture, and a prominent person coming in to moderate of all our 7 years. The first of many great things to come, and I'm very honored to be able to bring my teacher, Professor Dambachi, in. Okay. So what type of heart failure does the patient have? What do we think? The poll has not been set up. What do we think? What kind of heart failure does the patient have? The Prof said it now. Preserved ejection fraction. I brought this case out for those that just go to ejection fraction, or they want to do, they just, where is the echo? Surgeons use disturb us like that. Echo. When they bring echo, they just look at anything, they just go to the ejection fraction, 57. Oh yeah, let's go ahead. You know? So now we have to look at all of these things. Now, one of the things I want to point out also is that one of the new things that have come up and is very strong is the use of N-terminal pro-BNP. And there's a lot of work that has happened in Nigeria, typically part 2 dissertations on N-terminal pro-BNP and heart failure. And the sensitivity and specificity is quite high. So if you don't know what you are doing and you're able to do N-terminal pro-BNP and you see significantly elevated, chances are very likely that it is more likely to be heart failure. Okay? So if you don't know what you are doing, it is almost called the heart failure enzyme or the heart failure test. And even though all cardiologists do not agree that there can be a lab test that can that can conclusively diagnose heart failure, for the most part, it correlates with almost all cases of heart failure, that the N-terminal pro-BNP is. Now, in our practice in cardio care, truly there are times when there is a real dilemma. We are putting, once you train N-terminal pro-BNP, some matters can be settled, especially with E over E prime and calculating, some matters can be settled. Okay, fine. All right, so how do we treat heart failure? Remember the pathophysiology, and we said that there are 3 cardinal neurohormonal systems for treating heart failure. So, but I will tell you a 10-step approach for ACS. For ACS, number 1 is to educate. This, I believe, is the single most important step for treating heart failure in Nigeria. Education, not drugs. 99% of your patients that leave your consulting room will leave your consulting room to somebody else. For all my patients, I tell them let me prophesy to you. When you leave this room, somebody is going to tell you to throw away this drug. That person is going to tell you that they have one thing they will mix with this thing. That if you also you drink your early morning urine and you bath with salt, they'll be laughing. I say, no, I'm not laughing. This is a prophecy. And I assure you it will happen before you come for your next visit. Do you understand? If you don't go through that, most of your patients will go and not take their drugs. We have discharged a patient before. They left the hospital NYK class 3. After we struggled, ICU, everything. The man left from our hospital straight to the village. Threw away everything. Drank all kinds of things, including battery water, fridge, everything. Came back. That time when our old building, it with class 4 could not breathe, eyes like torchlight, yellow, hepatopathy. He was so sick, and that was our old small clinic. We could not even get him upstairs to the ward. He died in the consulting room there. He was so bad. There, no amount of inotropics. I don't know what they gave him. Kidneys were not. Everything was down. So this is in my opinion, in Nigeria, this is the single most important step. If you miss this step, you have missed everything else. And this step starts with educating us. That's why we are having this conference. Educate them on the disease nature. This is a chronic disease. It's not malaria. Once you get better, you cannot throw away your drugs. These drugs are costly and they are for life. Doctor, you mean I'll take it for life? You say yes. Doctor, but is there nothing I can just do and stop the drug? I ask them, can you just eat one food and stop eating? They say no. I say fine. You must take the drugs. Okay? On follow-up, on the need for specialist review, we are trying to start support groups in Nigeria. Okay, the endocrinologists have done Diabetes Association of Nigeria. We want to start some heart failure support groups. And we want to do it online, just with Telegram groups that we can follow up and support people. Then diet and lifestyle, and the need for procedures if and when it's necessary. This is the single most important thing. If you don't hear anything, please take this time and do it. Take 5-10 minutes of especially on the first visit. When it happens on the second visit, it's not as effective. But that first visit is critical. Okay. So call the patients, call the relatives, tell them on the reason for the medications, on how often, tell them about limiting fluid in some instances we don't limit fluid, but generally, teach them about a low sodium diet. Weighing scale is our glucometer in heart failure. Weighing scale is our glucometer. So they have their weighing scale, they have their blood pressure machine. Before they start having leg swelling and full breathlessness, more often than not, their weight will start moving to by 0.5, 0.7. So a lot of times, when I was in UCH, patients will keep that weighing scale. They will see it and they will know when to come to the clinic, and you will see before you reduce the heart failure admissions very significantly. And sometimes we teach them, especially if they are coming from hinterlands. Once you see the weight going more than this, and you know you've not overindulged, increase your fusemide dose a little bit. It will come down, you will feel better and come back. So weighing scale is one of the most important things. So now if you're a private practice, put it on your shelf. If you're prescribing the drug, let them buy. Now beware of psychological needs. You need to talk to them about the toll it will take on their life. It will toll it will take on their marriages. The toll it will take on their sex lives. The toll it will take on their occupational health. Otherwise, your patients will not cope. Then, you need to teach the patients about alarm signs and concurrent drug use. Okay? Nurses are better heeded to than doctors in my practice. And so, when the doctor says it, a lot of times, some people will leave even prof's office and ask the nurse, he said this, is it true? Some people in our clinic ask the gates man, this is what they said. I don't know. The man go say, talk the other day. So even you have to call the gate man and teach the security man. If not, he will say, leave that thing. I get something for you. All right. I know anybody that works in the hospital is a doctor in the community. All right. Use directives with caution. So the next thing, number 2, reduce preload and afterload. I've not yet gotten to the meat yet. So use directives with caution. Okay? And the aim of diuretic initially is to have a weight loss of 0.5 to 1 kg per day. And this is one of the criteria for diagnosis of heart failure. I think it's minor. Is it major? My head is tough. But that will help me. 0.5 to 1 kg weight loss initially. and then later to maintain as symptom free. This guy is hot from exam. Doctor, this person is hot from exam. All right. Typically, furosemide 40 BD or IV Lasix 20 to 48 hourly, or while on admission. Okay. Now, there were studies that compared, I think the usage, load, different strengths of furosemide use in admission and whatever. Of course, I fall on that category, and typically we looked at what IV Lasix being 20 to 48 hourly on admission has been somewhat the optimal dose for most of our patients and not causing severe hyponatremia and helping them out, except in severe cases. Now, you could also use torsemide or metolazone. Please, for everybody here, if you're not a specialist, don't touch metolazone, please. Don't touch metolazone, please. As much as possible. By the time you are getting problem or you have to increase higher, involve a specialist. You may not even deal with heart failure. Okay. Number 3. Remember I said there are 10 steps. Number 3 is to treat the neurohumoral abnormalities. The first abnormality was that RAA system, right? And so we want to give an ARB or an ACE inhibitor or an angiotensin receptor neprilysin inhibitor. Just ARNI, ARNI. In all of these 3, especially in reduced ejection fraction, ARNI is preferred. But ARNI is also a little bit costly. And a lot of our Nigerian patients have a very low blood pressure when they are coming to you. So they may not be able to tolerate it. So even though they say 50 milligrams BD, in actual practice, most times we cannot really start at 50. We typically start 25 and slowly build up. But it truly works in care. So we typically use any of these sets. Don't combine it. Never combine ARNI and any of these ones. If you combine ARNI and ACE, you are looking for trouble. You will not come out of that trouble. You will have killed that patient. So this is a mistake why also nurses are part of it. The patient was on lisinopril. Then Dr. Okopi came and said, you know what? I just came, I'm a consultant. Change to sacubitril valsartan. They just wrote sacubitril valsartan. They did not remove the previous one. And they gave 2 together. That is a mistake that can happen. The next time they are calling you, blood pressure is low, you are thinking stuff, high stuff, and you will forget just this. So you should never combine. And if you have to change from ACE inhibitor to ARNI, you need to wait for at least 36 hours. But if they had a dose this morning, you wait till maybe tomorrow evening or next tomorrow to start. Okay, just to be sure. Now, what I also do in my clinic is to collect the other drug from them. Because when they get home, patients can be relatively confused. Okay, so that's number 1 of neuroma. Number 2, virtually all patients, especially those with reduced ejection fraction, must be an aldosterone antagonist. And we're talking about spironolactone or eplerenone. Eplerenone is commonly available now, and from the studies, eplerenone is preferred more in patients with ischemic heart disease having heart failure. But really, it's between 6 and half a dozen. Okay? And sometimes it seems to be better for people that have gynecomastia, painful gynecomastia from spironolactone. Now, remember we're treating neurohormonal. We need to now treat also the sympathetic nervous system. So the beta blockers will come in. Beta blockers must be started low and you go slow and try to improve it. So bisoprolol, carvedilol, metoprolol, succinate. There's also nebivolol, but just keep it to these 3. BC, meta, they enter into a car. Bisoprolol, carvedilol, and metoprolol, succinate. BC, meta, they enter into a car. Right? BC, meta, they enter into a car. Don't give propranolol and say we said we should give beta blocker. Don't give atenolol and say we should give beta blocker. Okay? So these ones are, and metoprolol is not metoprolol tartrate. It's metoprolol succinate. Succinate, the long-acting metoprolol. Then we'll come to the SGLT inhibitors, empagliflozin and dapagliflozin. So you see that we are adding either ACE, ARB, or ARNI plus aldosterone agonist plus beta blocker plus this. These things will change the mortality of the patient. These 4 drugs, you have added them. You cannot add all of them at the same time. So sometimes, depending on the patient's blood pressure, but sometimes the patient can take it, do all that. There's a study that compares incremental adding versus adding all at once. And it just depends on the patient that you are seeing in front of you. These things must be there in a patient that you are treating. Furosemide will not change the patient's death rate. Digoxin hardly also. They might affect the patient to feel better, but the patient will still die per heart failure. Okay? So these drugs must be there. Not every patient can you start all of them on, and some of them you need specialist input to start. Okay. Number 4, treat the etiology. If you have done all of these things, concurrently, you may need to treat whatever caused it. Okay? If it's ischemic heart disease, beta blocker should be prominent in your therapy, and you may want to consider PCI. There's a study that there's a trial called Stitch trial, comparing giving PCI in patients with ischemic cardiomyopathy and whether they improve or not. Let me not go to all that. Patient with ischemic heart disease, you should consider this. Patient with valvular heart disease, you need to put surgery. Okay. Now, find the precipitant. Find the precipitant. When I was training, there was a patient we were struggling with. We were struggling with to manage the patients on the ward. The patient was not getting better. Man was not getting better. The man was not getting better. Then my oga just came in. And then he looked, we're talking. And he just said, where's this? Just got this. Then he just started laughing. He started laughing. And right there was atrial flutter hidden inside the QRS, just 2 to 1, but just very, I can never forget that thing again in my life. Okay? That was a mistake I made. I can't make again by the grace of God. So if you don't pick that arrhythmia or a chest infection or other things, you will never get that patient out. Sometimes the patient came with heart failure, but before they came to you, they were treated for malaria or typhoid, and they gave them 10 drips with Bico inside. 10. Okay, so you need to take care of that. Optimize other cardiovascular risk, blood pressure, cholesterol, blood sugar, and that's number 6. Optimize cardiovascular risk. Number 7, diet and lifestyle modification, low salt, water moderation, weight optimization, smoking cessation, alcohol cessation, symptom limited, moderate to. So they should do some exercise, but only as their symptoms allow. There's a patient I'd had with severe alcoholic. It looked like alcoholic cardiomyopathy, and I told him you have to stop. He said, doctor, because you don't drink, how can you ask me to stop? Okay, so but it's important. So I told him, my response to him was that this life is sweet. Ayedu, this life is sweet. Don't joke with it. So I've not seen him again for the past 3 years. I hope he's fine. All right. Treat comorbidities where present. If the patient has any other things, we treat the comorbidities. They have diabetes, calling the endocrinologist, treat the diabetes. We'll talk about diabetes management today. And assess for the need for device therapy. Okay? Before I go into this, let me go back to all we have said. Number 1, we said, yes, what's number 1? Educate, Abi. Number 2, hey, we have not gone far. We are still inside the hall. Some people are just saying, yes, what was number 2? Reduce preload or afterload. Number 3, treat the neurohormonal abnormalities. And we said, out of that, the first one is what? ARB, ANI, or AC inhibitors. ANI being preferred. Number 2, we said what? Under that one. Aldosterone antagonists, AA. Number 3, beta blockers. And number 4, SGL2 inhibitors. This is treating neurohormonal. And we see that this one is one of the key things that will prolong life. Thank you, Dr. Ojo. Thank you, I'm seeing you. These are not things that will prolong life. Dr. Ojo is a senior consultant ENT surgeon. He's retired from National Hospital. Retired. Yes, sir. All right, so number 4, treat etiology. Find any other etiology. Most times in Nigeria, because hypertension is the most common cause, while you are treating this, you're already taking care of the high blood pressure. Okay? Number 5 is what? Find the precipitants. Find and treat any precipitants. If the patient is coming with acute heart failure, look for it. And I told you the story about missing it on the arrhythmias, or the patient has an infection and you don't take care of it. Or the patient is on NSAIDs for some back pain or for rheumatism, as they call it. They are taking consistent and you are there. Okay? Number 6, optimize other cardiovascular risk factors. Other things, gout, CKD. Number 7, diet and lifestyle modifications. Okay? Number 8, treat the comorbidities where present. What does that sound like? I've said that before. Number 9, assess for the need for device therapy. Okay? So, for after you have treated with all of the above for at least 6 to 8 weeks of guideline directed therapies, you should consider repeating the echo plus or minus a Holter ECG. Which the patient has a high PVC burden on the ECG. If any guest with greater than NYHA2 with ejection fraction less than 35 to 40% should be considered strongly for device therapy. Ejection fraction is less than 35%, they should be considered. This is a class 1 indication. Class 1 indication, meaning this indication is very strongly recommended and it actually helps. So, if the QRS duration is normal, we'll now think about doing an ICD. If the QRS is prolonged, we now think about doing cardiac resuscitation therapy. Yes, I know it's not cheap, but it is what you are supposed to do. And I always tell my patients that if it was my father, what would I do for him? This is what I will do for him. Okay? And so this is the class 1 indication for device therapy in heart failure. Any patient. Anybody that has had a cardiac arrest and survived it, or have a high ventricular tachycardia burden, should also be considered very strongly for an implantable cardioverter defibrillator. Very, very important. Very, very important. Okay? So this is what we need to do for all our patients. So you see the ejection fraction 30%, you say come back next time, mama. 3 months again, come back later like that. In the next 3 months, you will not even remember. You will not see mama. You will not see mama. This have been proven in part of my training in healthcare management. We did analyze the studies. Looking at CRT therapy in prolonging of life, and it is quite significant. CRT in that study, which we used, called the Markov model, is an economic model. So some of us should go to healthcare economics. We use the Markov model, and you see that CRT increases length of life by up to 5 years, and up to 3 years quality adjusted life years. Up to 3 quality adjusted life. So it's quite important. So somebody that qualifies versus somebody that does not qualify, the studies show that you add an extra 5 years plus, and including 3 years of improved quality in those patients. Okay, we don't yet have Nigerian studies, but that is the European studies. Okay, so I'll jump this. And number 10, monitor for clinical progress, complications, and quality of life. I did a work on quality of life in heart failure, and there are several things you can, even if you don't use the standard, what they call it, questionnaire, you can ask the patient, how are you? Don't just ask how are you, they'll say fine. Fine is the correct answer for how are you. But ask them, how is your work? Are you able to dress up yourself? Are you able to go to the mosque? Are you able to go to the church? When you go to the mosque, can you pray normally? How does that make you feel? Does that affect that you cannot pray like other people? You may sit down or something. How does that make you feel? Can you go to the church? There was one guy that said he noticed that he was a drummer in church. He said he could not play drums again. By the time after 2 minutes, they have to call somebody else to come and take over from him. And that put a lot of distress on him. You need to address that. You need to address that. You need to look at all of those things. Number 11, psychosocial support. This is where our heart failure group should come in, our heart failure nurses should come in, our clinical psychology should come in, even the cardiologist should come in. But in our Nigerian setup, these things will be more effective. We find it much more effective for a patient with a pacemaker to talk to another patient with a pacemaker than for a doctor to talk to a patient. They can relate, say, no, that kind of thing, don't scratch it like that. Just do your hand like this, it go scratch. You know, those kind of things. Doctor cannot know that. You have never had a pacemaker before, no matter your stuff. Okay, so it's very, very, very important. And number 12, multidisciplinary management. The 12 rules of heart failure. Everybody is involved. Dietitian, pharmacist, health information management officers, so that they can track down the people that have not come for follow-up. They can track down the people that are left behind. Other physicians, counselors, cardiac surgeon, interventional cardiologists, cardiac device technologists. We have a company that is selling cardiac devices. I think they are there at the back. Thank you. What's happening? Oh, something is burning. You force them in as the patient. Now, there's something that is not here, which is how to start those drugs. You typically will start low and then you will go slow. So you will start at the lowest possible dose and then you will go slowly. Over time, you will now try and increase it slowly to the highest tolerable dose. I have a patient that is on ANI at 200 milligrams twice a day. But remarkably, her ejection fraction has gone from either 40% to 65%. Dr. Olaleko remembers the patient. Ejection fraction has gone to normal. E over E prime has come down. N-terminal pro-BNP has come down, and she's maintained on 200 milligrams twice a day. Now, most of our patients can hardly tolerate more than 25 milligrams twice a day, or barely 50 milligrams BD. So you go to the maximum tolerable dose. So if you start with, sometimes beta blockers will start with 1.25, and then we slowly try and get to 10 for bisoprolol. Okay, and that's that. So I'll just take any questions. If you have any questions, please. Where's the microphone? Just raise your hand if you have a question, and if you are too shy, just write your question down. Is somebody there? Who's it? What? Novartis, are you ready?
All right, thank you for the wonderful presentation. Just to go back to the case that you gave us, you said that the diagnosis of heart failure is physical. But you remember we couldn't diagnose it before you gave us the labs, and Prof didn't agree that it was heart failure yet until you gave us the lab results. So why are we still sticking to that definition of only physical when we can complement it with, labs, and we're in the 21st century, I mean. My second question is, what? My second
Some
question.
things have not changed. Have you been to an exam and they say, has the teaching changed? Once you hear that statement, know that you have failed.
Okay,
right,
my second question: what racial concerns would you put in place with these medications? I mean, you wrote out isosulfide down there, and any considerations? What other considerations would we put in place while using ivabradine as well? Thank you.
All right. Number one is that I will not advise non-specialists to commence isosulfide hydrazine or ivabradine. By the time you are getting to those ones, specialist care should have been instituted. Please, as much as possible, I will not ask you to start it. I just wrote it for the sake of completeness of the slides. Okay, so please, I'm not saying that you should go and carry hydrazine and give isosulfide and mix it. Please, it's just for completeness. Okay. What's the question? Clinical diagnosis: heart failure remains, will ever be a clinical diagnosis. As it was in the beginning, is now, and evermore shall be. World without end. All right. I know that we are in the 21st century. However, it is still, the reason I did the case like that was just to bring out salient things as we're going along. You will not see a patient and then just stop. And I left out key chunks of the history and key chunks of the investigations that will have helped. Okay. Yes, please, sir.
Yeah. Radiological cardiomegaly did not appear from the blues. If you do a thorough physical examination, you would have detected a cardiomegaly or a displaced cardiac apex. So the radiology just confirms. Investigations are meant to confirm your suspicion. All right? So it's not a new discovery for you. All right? So if I see a patient with a cardiomegaly, or a displaced apex, and he has a pedal edema, and he has shortness of breath on exertion, is decompensated. This guy has already decompensated. I mean, whichever way you look at it, all right. And okay, Seko, since I'm on the phone, I will also say this, that sometimes I tell or I ask my resident doctor, what is the non-cardiac treatment of cardiac failure? Can I repeat it again? Interesting question. What is the non-cardiac treatment of cardiac failure? Actually, it was there in the slide. Yes, it was there in the slide. The patient's sleep is important. He will not die with bromazepam. He will not sleep. He will not sleep into death. So if he requires a bit of bromazepam to have a good sleep, he needs it. Sildenafil, yes, he will need it. Yes, he will need it. But then you have to be cautious. So that's why you are coming to the specialist. It's depression. Because cardiovascular patients have depression. All right? So you need to take care of his depression, because otherwise his adherence to his drugs will suffer. All right? His adherence to his lifestyle will suffer. Very, very important. Now, lastly, I will also say, Dr. Iseko, I wanted you to have flipped a slide on, because this is practical and very, very important, on acute heart failure. Acute heart failure, acute left heart failure. Hypertension is our problem. They come in, and then the unsuspecting physician says asthma, because it happens in the night. He wakes up, he has paroxysmal nocturnal dyspnea, he wakes up, he's gasping, looking for breath, and he comes to the unsuspecting doctor, and the doctor says, oh, this is asthma, aminophylline. Well, aminophylline might help, yes, might help, but hypertension, acute left heart failure, and I think we see a lot of it. We see them, and then the other aspect is pulmonary embolism, right heart failure, acute right heart failure. Again, we cannot take this one away. We see it in our practice, and it's part of our practice. That's why I'm your teacher. Thank you very much.
Thank you very much, sir. We have a number of questions. Some of these questions are another presentation. So one of the questions says, management of heart failure in a patient with shock. Management of heart failure in a patient with shock. So by shock, I presume you mean that the blood pressure is low. I presume you're talking about cardiogenic shock. If it's hypovolemic, that is the patient had severe diarrhea, and then the blood pressure went down from fluid loss. In such a case, you still have to correct that fluid therapy. You have to give fluid therapy to correct that. But you have to be cautious, because if you give too much fluid, you are going to overload the lungs and going to have an issue. All right, so the best approach to that management is management in the ICU setting, standard approach, and then to have a central venous pressure line so you can manage and check the central venous pressure. That will help guide your fluid replacement so that you don't give too much fluid. Now, ICU setting with CVP monitoring and intra-aortic balloon pressure monitoring is not readily available in a lot of centers. What do we do instead? The most sensitive indicator of tissue perfusion still remains urine output. So, pass your urethral catheter, measure urine output hourly, give your fluid cautiously, and you use the poor man's CVP pressure line, JVP, and monitoring of crepitations on the lung basis if you don't have the proper, but it is not the correct way to do it. Ideally, you should have that. Now, all patients with heart failure and you are giving fluid should be giving fluid with an infusion pump and never just by drop measure. So if the patient needs fluid for any reason, The ideal thing is to use an infusion pump so that the relative don't come and say this fluid that is not going fast. Let's open so they can get discharged well. Piam. Or the nurse closes it to give one drug and then opens it. They just go, this is on Instagram. Piam. Next thing you come. Okay, so ideally, in the ideal setting, and in most places abroad, there is nobody gives fluid just by counting drops. Put the infusion pump there. Okay, now that is one angle. In the aspect of a septic shock, antibiotics in addition to other septic things. In the presence of cardiogenic shock, now you need to now do everything we have said. Number one, educate the patient and the family. Number two, find the precipitant. What caused the cardiogenic shock? Sometimes it could be an arrhythmia and you need to treat that arrhythmia. Sometimes it could be an MI. The patient could be having an ischemic heart disease that caused it. That could be the problem. So you need to put that in place. Now, having treated the precipitants, you will need to take away most of these drugs that reduce the blood pressure. And then inotropes will need to come in. And this cannot be done outside an ICU setting as much as possible. In these cases, please do not manage these patients with heart failure, with cardiogenic shock without a specialist. Even if the specialist on phone, if you see on the tables, you will see a QR code that you can use to join the medical symposia community. So what we do on that group is people with difficult cases or ECGs sometimes post it, or cases they post it. We only have one rule. As you post the case, post what you want to do so that we can now correct you. Don't just turn me to the person managing your patient. You post the case, say that this is what, if you post an ECG, we will have taught you, you will say this is what is there, then we will now say correct or add this, add that. So all the consultants here are on that group. So you can join the group and then we can help you on the go. But that is especially if you're in remote areas. Otherwise, make sure that you have specialist input. Okay, so I will need to stop now because of time. Other questions, if we have some small time, we'll try and answer them.